I'd like to introduce Peter Thomas.
Thank you so much, Suzanne. I appreciate the introduction. It's great to be here in St. Louis, and what I'm going to try to do today is talk a little bit about, well, talk a lot about the Affordable Care Act, which is the health reform law that passed in March of 2010. And try to do a little bit of a refresher on exactly kind of what it does and what's intended to do, and put the medical home concept in perspective, put it in a framework of that concept in the context of overall health reform. Try to give people a sense of where it fits in and how important it is. So I don't want to get too deep into the weeds on health reform because, frankly, with a system like ours that is so fragmented and so complex, I don't want to lose sight of the fact that this is a conference ultimately about the medical home concept and about moving forward with that. But I think it helps to try to understand where exactly that comes from and how that fits into the broader picture, the broader puzzle. So, without further ado, and by the way, I have about an hour. Okay. And feel free to ask questions during the course of my remarks. I don't need to wait until the end or anything. Just feel free to go ahead and ask. It's kind of, I barely see you here. All right, so the first thing I'm going to do, I'm going to kind of talk about an impending kind of policy train wreck that is really gearing up for the end of this calendar year, and I'll tell you exactly kind of what that means. I'm going to go through healthcare reform and do an overview of what the bill was intended to do and how it's being implemented. I'm going to talk very briefly about what the Supreme Court of the United States said about the Affordable Care Act and in upholding that law. And then talk about the regulations that have been streaming out of the Department of Health and Human Services for the last 2 years, 2.5 years. And then an outlook on healthcare integration and medical homes, and try to place medical homes again in the context of the broader set of reforms that the Affordable Care Act brings to the health insurance field and the health care system in this country. So the impending train wreck. This is a kind of a word that's being used in Washington these days to describe what's going to happen at the end of this year if Congress does not act to create an alternative to what's currently scheduled, what the law currently is scheduled to bring in terms of tax policy, debt reduction, entitlement reform, and a whole host of other things. So just to give you a sense of what we're in store for, right now, because of the national elections, there's kind of a policy paralysis in Washington. Nothing's really happening. And there's huge events that are about to take place. Well, a lame duck session of Congress is after the election has occurred, but the new Congress has not yet been seated. The new Congress gets seated the first of the new year. So between the 8th of November, Election Day, and December 31st, that's known as a lame duck session of Congress. And many times, Congress does not meet during that time period. They figure the folks who have retired really shouldn't be voting anymore. The people who have lost their elections really shouldn't be voting anymore and binding the country to do certain things. And yet, they still are a sitting Congress. And so if there's an emergency or if there's a particularly, a lot to do before the end of the year, they will have a lame duck session of Congress. And a lot will depend on what happens with the presidency and whether President Obama is reelected or Governor Romney is elected for the first time. And a lot will depend on where the Senate lies in terms of who controls it. Right now, the Democrats control the Senate. And if the Republicans take back the Senate and control the Senate and the House, I think there's going to be, it's a much different situation than if the Democrats continue to retain control of the Senate. So, what's in store? The first thing is that sequestration is set to hit on January the 2nd. Sequestration is across-the-board spending cuts to the tune of about 7 to 10%, depending on who you speak with. In fact, today the Obama administration is supposed to release an analysis on what sequestration will mean for every single federal program across the spectrum of the federal government. Sequestration was put into effect as a stopgap so that Congress could do the heavy lifting and sit down and negotiate with each other to try to figure out a way to reduce $2.4 trillion in spending to offset the cost of extending the debt limit back in the summer of 2011. If you recall, last summer, all the leaders of Congress and the President were sitting down, meeting after meeting after meeting, to try to figure out how to reduce the debt by $2.4 trillion, which is not a small number. And that was done to try to offset the increase in the debt ceiling, because we are borrowing too much money, and we only, as a country, have the authority to borrow so much money, and we were about to exceed that limit. And the Congress had to raise that limit. And the Republicans said, primarily, the only way we're going to raise this limit is if we offset it with spending cuts. The problem is that they weren't able to agree on about half of the spending cuts. They did agree to cut programs over 2 years, fiscal year 2012 and 13, but they did not agree on the larger set of package of spending cuts to offset that debt limit increase. And so these across-the-board cuts are intended to bring those cuts to the table and just do it across the board. Not have Congress pick and choose particular programs, but just have an across-the-board spending cut. God bless you. And it applies to not only non-discretionary programs like the CDC and the FDA and the NIH. It applies to programs across the board in defense. About half the cuts will come from defense, and about half the across-the-board cuts will come from other federal programs, not including Medicare, Medicaid, and Social Security. Actually, let me amend that. Not including Social Security and Medicaid. Medicare will be cut by 2% on provider fees starting on January 1. So there are a lot of budget hawks, there's a lot of defense hawks, there's a lot of people trying to protect social programs that are clamoring for some kind of alternative to these draconian across-the-board cuts that are set to hit on January 1. And yet, the election season has really hampered any kind of true negotiations to try to figure out a path forward. So at the end of the election, when the election's finished, the dust settles, the Congress will have no more than about 4 weeks to sit down in earnest and to try to figure out exactly what they're going to do before the 1st of January, before sequestration kicks in. In addition, the physician fee schedule under the Medicare program, which therapy providers are also compensated, reimbursed under, that will take a 29% cut unless Congress intervenes and pushes that down the road and grants a small update or a 0% update, as they have every year for the last 13 or 14 years. That's another big issue. The next issue is the debt ceiling. Again, is going to need to be raised probably sometime in January, and that's going to set off a whole new round of debates about what we do to offset the cost of that additional federal spending. The Bush tax cuts expire at the end of this year, so there's going to be all kinds of people promoting the notion that we extend the Bush tax cuts again. I think the Obama administration would say don't extend them for the top 2% of earners, but everyone else should receive an additional middle-class tax cut. And if that's the case, that costs a lot of money. They've got to offset that with spending cuts in another way. In addition, unemployment benefits for people who are currently unemployed are scheduled to expire. The payroll tax cut, which is a 2% tax cut that's been in effect now for 2 years, that also expires. And so if Congress doesn't do something to change that, everyone's taxes, everyone who works, taxes will go up by 2%. And then finally, there's a new medical device tax and a new Medicare high income tax, both of which are set to go into effect, and both of which are in the Affordable Care Act. And so there's a whole confluence of tax policies, budget problems, debt problems that are all going to come due at the very same time that there's a whole bunch of turmoil in our politics in terms of who is calling the shots and who has the power in Washington. So I don't mean to scare people, but that's a pretty serious set of events that's about to hit us. And we will see where Congress goes with this. MedPAC is a an entity that advises Congress. It's called the Medicare Payment Advisory Commission. And they meet and they make recommendations to Congress to change Medicare policies. And they've suggested a whole bunch of policies that impact post-acute care. There's really in Medicare, writ large, it's kind of hospitalization and hospital care, which is the vast majority of spending under the program. And then there's post-acute care, and that is everything from outpatient, therapy to, durable medical equipment, home health care, skilled nursing facilities, long-term acute care hospitals, all the different types of post-acute care that's provided, and the rehabilitation that's covered under the Medicare program. Well, there's a whole bunch of recommendations on the table that save a lot of money, and many of these will impact providers of these different types of services. So they've proposed, MedPAC proposed, no inflation update to inpatient rehabilitation hospitals and units. They've suggested no inflation update for long-term acute care hospitals. They've suggested a rebasing of the payment rates for home health care. And when you talk about medical homes, home health care, and the fee schedule for home health care is one major way that providers under medical homes get reimbursed. So that's a big deal. To rebase that, that basically means that they take whatever costs that they're spending on home health care and they adjust them downward and start paying providers less than they are now. And that kind of readjusts the baseline, if you will. It's kind of a technical term. They're thinking of rebasing the skilled nursing facility payment system. Those two programs alone would save $33 billion. Those are that's big money over a 10-year period. And then apply the readmissions policy, which is a new policy for acute care hospitals, and apply that to all these other settings of post-acute care. The readmissions policy says that if you've got a patient that came in to a hospital, received care, was released, maybe a little bit early, maybe without being fully well, and then returns to the hospital within a 30-day period and gets readmitted. Right now, Medicare pays that hospital twice for the same patient. The readmissions policy says if you have a person that is readmitted within 30 days to the hospital, you get a decreased payment the second time they're back. And if you have a disproportionate number of people that do this, you get hit financially. And it's a disincentive to hospitals to release people early and and an incentive to make sure that they're well and they're cared for after the hospitalization is over. They're thinking of extending that policy to many other areas of post-acute care. Those are just a few of the proposals that are being discussed that impact medical homes and impact post-acute care and rehabilitation for people with disabilities and chronic conditions. And I thought I'd just mention them. There's many more that are on the table, but those are some of the highlights. So let me pull back for a second from that budget discussion and retrace our steps on the Affordable Care Act and the National Healthcare Reform. Because it's been so misrepresented in the media and very few people truly understand what the bill does and what it is intended to do. And so I wanted to just give a little bit of a refresher course in that. The first is that PPACA, which is the Patient Protection and Affordable Care Act, that's healthcare reform, passed in March of 2010. And it really does have major implications on rehabilitation providers and people with disabilities and chronic conditions. The insurance industry, a lot of people miss this, but the insurance industry supported this bill. The American Medical Association, American Hospital Association, lots of organizations that are consumer and disability oriented, all supported this bill. Why is that? Because the insurance industry came to the Obama administration and said, we think that the system is broken as well. The only way we can eliminate pre-existing condition exclusions, the only way we can change the rules of insurance is if everyone is under the tent, if everyone is covered. So right now there's like 50 million people in this country that don't have health insurance. And so the goal would be to try to get, and that's about 83% of the US population, has health insurance. It's about 17 do not. The goal was to get about 94 or 95% of the American public covered by insurance, so that you wouldn't have people going to the emergency room for primary care. You wouldn't have people, there's a statistic that says that people with insurance pay about $1,000 a year as a subsidy to people who don't have insurance. In other words, those costs are spread in the system. And so the theory being that if everyone is covered, if you need care, you'll have a payer that will help you pay it, and costs overall will be at least stabilized and hopefully will go down. It also suggests that if you get everyone under the tent and everyone's covered, you can reform the rules of insurance. Right now, if you go to an insurance company under the current rules, you go to an insurance company, you want to be covered. They will medical underwrite you. They'll ask you about all your conditions. They'll ask you what kinds of doctor's visits you've been to, what's your claims history, what is your hereditary history, what's your, what is your, at what age did your parents pass away if they did. They'll ask all these questions to try to try to assess the risk that you pose to them. And then they'll give you a premium that reflects that risk. And oftentimes, if you've got a chronic condition or a disability or a health condition, you're not going to get insurance. You're going to be completely medically, they will not underwrite you. You'll essentially be boxed out of the private insurance industry. Even if you do get insurance, they will oftentimes, they, meaning the insurance companies, will rate you in such a way that the cost is just prohibitive. You can't afford it. And there's really very little help out there to subsidize the payment, the coverage of those premiums. So you wind up out of luck. And the only way that you can possibly get health care if you really need it is, obviously if you have an employer that provides it to the extent that they provide it, you can access it that way. If you don't, then you really have to go onto a public program. And that usually means you need to spend down and spend your resources down to the point where you qualify for Medicaid. It's no way to run a railroad. It just is not. The system is broken. And so this bill attempted to say, we'll allow people to have no medical underwriting. We'll no longer discriminate based on disability or health status or chronic condition. We'll make insurance easy to obtain and provide federal subsidies for people who can't afford it in order to get them to be able to afford it. And if you're really low income, we'll allow you to join on to the Medicaid program and an expanded Medicaid benefit. And we'll bring the number of people who are insured up to about 94, 95%. And in that way, we'll completely rewrite the rules of insurance. And the insurance industry said, we're on board. And the AMA said, we're on board. And everyone said, good deal, let's hold hands together and make this happen. And so that's what this bill does. Now everyone's kind of blaming each other for this bill that's going to bankrupt our country and socialism. You can really demagogue this issue, and a lot of people have for a long time. But the bottom line is, when this bill passed, a lot of people were in support of it, and throughout the course of it being passed, a lot of people came to the table and supported it. So what are some of these insurance protections? Well, in exchange for 16 million new people in the insurance industry and getting private insurance through state-based exchanges, which are new insurance markets that will be created in 2014, assuming President Obama is reelected. If he's not reelected, I think this whole thing goes out the window, or at least most of it does. So 16 million new people on private insurance with or without federal subsidies to help them afford it, and about 16 million new people on Medicaid, in a whole new category for low-income adults who don't otherwise have insurance. That's about 32 million new people entering the insurance market, having coverage that don't have it today. That's a huge boon for healthcare providers, hospitals who currently have to treat anyone who shows up, but sometimes they have no way to pay for it. That's totally uncompensated care. That's going to transform the whole healthcare field. Now you might ask, do we have the capacity to serve all 32 million new insured people? That's a really good question. I mean, right now the current system probably does not. So there'll be probably a lot of jobs created in the healthcare market to try to satisfy that need. But I digress. The rules of insurance are in 2014 completely rewritten. So no discrimination based on disability or health status. That is a huge transformational rule in the purchase of health insurance under this country. Number two is guaranteed issue. The insurance company has to provide an insurance policy to you if you go to them and want to pay for it and are able to pay for that premium. They have to provide it to you. They can't deny it to you. And they have to renew it. after the time period is up for a renewal. They cannot impose any pre-existing condition exclusion on you, and so that they can't say, well, you've had a mental health condition and therefore we're not going to cover anything related to that. They can no longer do that in 2014. Right now they can't do it with children. It extends to adults in 2014. They can't rescind your policy. Right now there's instances where insurance plans will hear about a beneficiary who all of a sudden develops a major condition, a costly condition, and they'll look through the history of the individual's file and they'll find evidence of some condition that they didn't disclose on their policy of insurance and their application for insurance, and they'll say, well, your policy is rescinded, you didn't tell us all the information. That will be prohibited going forward unless there's abject fraud in that process. And finally, there's community rating, which or premium rating, which only allows the premiums to differ based on age, geographic status, family status. In other words, if you're only applying for an individual policy as opposed to a family policy, the insurance company can charge a different premium for that. And smoking status. And smoking is limited in how much they can penalize you for that. And then finally, there's no lifetime caps or annual caps permissible in private insurance after 2014. And so people with brain injuries, people with sickle cell anemia, people with all kinds of conditions that are quite expensive to treat over the person's lifetime, there will no longer be any lifetime or annual cap imposed on the care that they receive. And so those are all important protections for beneficiaries and enrollees, and major changes in the insurance market. There's more. There's risk adjustment. Risk adjustment is a situation where they make sure that plans are compensated, are reimbursed based on the risks that their particular population has. And so if a plan winds up getting a higher percentage of sicker and older beneficiaries, the plan that wound up getting the younger and healthier beneficiaries actually has to pay through these state-based exchanges the plan with older and sicker beneficiaries and ultimately share in those risks. And so that's risk adjustment. There's also reinsurance that is mandated for the first 3 years of this program, 2014 through 2016. All of those are relatively complicated insurance mechanisms that essentially spread risk and allow the people with disability and chronic conditions to get a better deal. There's also a provision that allows young adults to stay on their parents' private health insurance plan up to age 26. That alone was responsible for 1.3 million people last year gaining access to health insurance. The number of uninsured actually went down last year, even in this recession we're in, because of this provision alone. And there's as I said, there's new exchanges and state implementation of new insurance markets. There's also a medical loss ratio, which says that health plans, private insurance companies, have to spend between 80% and 85% of the premium dollars that they receive from enrollees. They have to spend that amount on medical services, not on CEO salaries or marketing or other kinds of non-healthcare related functions. And finally, there's an essential benefits package that has to be covered under every private insurance plan. And that includes really important benefits like rehabilitative and habilitative services and devices. It includes behavioral health care, mental health care. It includes chronic chronic care coordination and disease management. It even includes oral and dental services for children. And states are in the midst of rolling out and trying to figure out exactly what's going to be in their essential benefits package. So before I get into essential benefits, this is huge. This is a sea change in insurance in this country. And it means a lot in 2014 for this to go into effect. Again, I don't see this going into effect unless the president is reelected. If Governor Romney is elected, He's already said that he would repeal the Affordable Care Act, but he would pass a bill that did a few of these things, like eliminate pre-existing conditions and things like that. Although I don't see how you eliminate pre-existing conditions unless everyone is covered, but that's a whole other debate. Okay, so essential benefits. Right now, the Department of Health and Human Services at the federal government level pushed down to the states the responsibility of creating the essential health benefits package. It was kind of assumed that the federal government would do that, but they didn't want to create a one-size-fits-all package. So they said to the states, here's some guidance, here's some principles we want you to follow. Now, you go design your own state essential health benefits package that works locally, that works in your state. But there's not, there is specific guidance in the statute to help the states, and in my view, to help people with disabilities and chronic conditions get a benefit package that helps them. Because if you're a person who needs a benefit that's not covered by the essential health benefits package, it doesn't really much matter that you have health insurance coverage. You can't get what you need. So it's really important that the essential health benefits package is robust enough and broad enough to cover what you need. So there's these requirements in the statute that the essential health benefits package in each state cover an appropriate balance of benefits, that it not discriminate in benefit design based on disability status, that it covers the healthcare needs of diverse segments of the population, including people with disabilities, that it's not decided, that they don't decide on what to cover based on a present or predicted disability or degree of medical dependency or one's quality of life. And finally, this benefit package needs to be updated periodically. So what has to happen with the essential benefits package, as I said, Department of Health and Human Services issued non-binding guidance on the states to try to help them develop their own package. There's still not a proposed regulation or a final regulation out on this, and we expected that last year. But we do expect there to be one after the election. What the state is supposed to do is define and choose a benchmark plan, and then do certain things to that benchmark plan to enhance it and make sure that it's in compliance with the statute, with the Affordable Care Act. So they have to choose one of many different options, but most states are choosing the plan that is currently functioning in their state, that's a small group plan, the largest small group plan. And if they choose the largest small group plan, the federal government will cover the cost of whatever state benefit mandates are covered by the state for a 2-year period. So it's kind of an enticement for the state to choose the largest small group plan functioning in the state. This deadline for choosing these benchmark plans is fast approaching. It's September 30th, although I've heard recently that the Department of Health and Human Services is thinking about pushing that off until November. And even so, it's just guidance, it's not a requirement. After that benchmark plan is selected, the state is supposed to go in and enhance that package to make sure that it covers every one of the 10 categories of benefits that are listed in the Affordable Care Act. One of them being rehabilitative and habilitative services and devices, mental health care, behavioral health care, chronic disease care coordination, as I said earlier. States would then apply all those non-discrimination provisions that I just mentioned, the appropriate balance, if you can't discriminate based on disability, and then make some calculations to make sure that it's affordable and that it fits within an actuarial range. And it does say that that the plan cannot have dollar limits. It cannot say you can only have a $2,000 benefit for durable medical equipment. But they can have certain limits in terms of numbers of visits. So they can say, for instance, 20 PT visits or physical therapy or 20 occupational therapy visits, something along those lines. But they cannot have dollar-based limitations in the benefit package. So that's what's taking place right now as we speak. States across the country are selecting their benchmark plans and are trying to figure out exactly what they're going to cover and how they're going to cover it in 2014 and beyond. So as you know, there were 2 major threats to the Affordable Care Act and implementation of the Affordable Care Act. The first was the Supreme Court review of the case. And that occurred in March, and the final decision was made on June 29th. The second, of course, is the upcoming election. The Supreme Court reviewed 4 different legal challenges with respect to the Affordable Care Act. The first was that the individual mandate, the mandate that every individual has to purchase health insurance or be otherwise covered or pay a fine for not being covered, the states and other entities asserted that that was unconstitutional. In fact, the Supreme Court upheld the constitutionality of the individual mandate, but not based on the reason that most people assumed they would. And we don't need to go into the detailed reasons for that unless people have questions about it. But the bottom line is that the Affordable Care Act was upheld, and that every person in 2014 is mandated to purchase or otherwise have health insurance. And again, if you can't afford it, and you're less than 133% of the poverty level in terms of your income, you will get access to Medicaid, and if you're between 100 and 400% of the federal poverty level, you'll get federal subsidies on a sliding scale to assist you in gaining access to that coverage. Because the mandate was upheld, the next issue is whether that provision was severable and from the rest of the law, and whether the rest of the law would survive or not becomes moot. It wasn't an issue because that only takes place if the individual mandate was struck down and it was upheld. And then the jurisdiction issue down below is kind of an esoteric tax issue that I won't get into. But the main issue, the main impact of the Supreme Court's ruling was the Medicaid expansion. The way the law expanded Medicaid was to say to the states, we are going to allow you to expand your Medicaid program, and we are not just allow, we are going to mandate that you expand your Medicaid program. You don't have to do it, but if you don't expand your Medicaid program according to this law, you get no Medicaid funding going forward. You lose all federal funding for Medicaid. That's a huge axe over the head of the state. And the Supreme Court viewed that as coercive on the states. And so the Supreme Court said, you cannot mandate that states implement the expansion of the Medicaid program. You can only provide the federal funding if they do. And so the mandate, the expansion of Medicaid is completely voluntary. Each state can choose how high it wants to go in terms of covering people, how many it wants to cover. If it doesn't want to cover any new people under Medicaid at all, it can do that. If it wants to cover people for a certain period of time, 2-3 years, and then eliminate that coverage, the state is permitted to do that. And so this is a very voluntary approach now to expanding Medicaid. And already we've seen 6 or 7 states say that they have that they intend not to expand their Medicaid programs. Texas, Florida, South Carolina, Louisiana, Alabama, those states have said basically that they're not interested in expanding their Medicaid programs. Of course, this is a pre-election season. So remember that the federal government spends 100% of their money on Medicaid expansion for the first 3 years. The state doesn't put in anything. So this is free federal money flowing into the state to cover people who currently don't have any insurance at all. And after that, it slides down to 90% to 10%. So if the state puts in $10 to cover their people, they can pull down 90% or $90 of federal funding. Now put aside the issue of whether the federal government can actually afford to do this, because there is a legitimate question about that. The fact is that this is a great deal for states, and for states to be balking and not expanding their Medicaid programs is really a bit odd. And I think, frankly, after the election takes place, you're going to see a lot of those governors fall into place and agree to accept and expand Medicaid through this program in 2014 and beyond. There's just going to be too much pressure from hospitals that are getting people coming into their state that are uninsured, that are coming into their hospitals that are uninsured, where they don't have any way of getting any kind of payment when a Medicaid program with 100% full federal funding is available to the state. I just look at the history of Medicaid in 1965, look at the history of the state children's health insurance program in 1997. All 50 states participate in both of those programs. And so I just don't see where long-term it's viable for states not to participate in this expansion of Medicaid. But that's my point of view. So 2014, about 16 million new people joining Medicaid. There are 7 states, as I said, that are not in. Now, even with those states joining the Medicaid program, and even with this expansion being upheld but modified and making sure that it's voluntary, and even with a lot more dollars going in to fund Medicaid coverage of people that don't currently have health insurance, the Obama administration is still putting about $65 billion worth of Medicaid cuts on the table for the purpose of deficit reduction. And they plan on doing this, or they propose to do this, by melding the different payment rates that currently states receive for both Medicaid and the state children's health insurance program. The matching rates for federal to state dollars are all over the map. And what the Obama administration is recommending is that they condense that and create one matching rate. They blend the matching rates and thereby save a lot of money from the federal government going to the states. However they do it, it's less Medicaid funding going into the state at the very time that they're trying to cover everyone with health insurance. And so this is a little bit of a disconnect, but it is on the table and it is being discussed in the context of deficit reduction and long-term debt reduction. There's other problems with Medicaid, and that's mostly in the existing program. Right now, governors all over the country, and for the past 2 or 3 years, they've been under great stress to try to reduce their Medicaid expenses to try to balance state budgets. And right now, there's a maintenance of effort provision on every state to not dump anyone from the Medicaid rolls. There are 3 ways that states can decrease their Medicaid expenses. They can cut reimbursement, provider reimbursement rates. They can eliminate benefits or reduce benefits, or they can eliminate individuals from the rolls and no longer cover them under Medicaid. But the Affordable Care Act set in place a maintenance of effort provision with respect to that last one. They can't dump people from the rolls. They can't dump any adult until 2014, and they can't dump any child until 2016. So that has prevented a lot of people from losing coverage in the meantime during these years leading up to 2014. But clearly, Medicaid is a major cost to the states, and a lot of the states, especially with governors that don't particularly like Medicaid and would rather transform Medicaid into a block grant program and have a lot more authority to do with those funds what it wants to do. They are pushing back and trying to figure out ways to reduce Medicaid costs. There's also, and one of the ways they're doing that, by the way, is to accelerate the imposition of mandatory managed care for Medicaid beneficiaries, including Medicaid beneficiaries that have severe disabilities or intellectual disabilities, developmental disabilities, and those are populations that usually have not been exposed to mandatory managed care in the past. So there's a whole new frontier of mandatory Medicaid managed care for those populations going forward. All right, so let me just touch upon the delivery system reforms. In addition to all those insurance reforms and Medicaid reforms, there really is a whole new way of thinking about care and the delivery of care, and that's where the delivery reforms in medical homes come into play. The theory is that this country largely rewards volume of services rather than the quality of care. And so all of the proposals and all of the authorities that are in the Affordable Care Act that are delivery system reforms are meant to decrease the reliance on, if you provide a service, I will pay you $1 for that service, and instead move toward, if you provide a set of services and that person does well and succeeds in their care, then we will pay you based on that success. And that's what this whole kind of set of delivery reforms is moving toward under the Affordable Care Act. And you can see it in the hospital readmissions reduction program. I talked a little bit about that earlier with respect to people who leave the hospital and get readmitted. You know, those hospitals are going to get financially penalized if they continue to do that in a a serious way and don't address the readmissions issue. There's also something called the value-based purchasing program, and that's where Medicare withholds a certain amount, 2 or 3%, of the reimbursement rates that they pay hospitals. They withhold those dollars build up in a pool, and at the end of the year, the federal government looks at a variety of quality measures that these hospitals report on, and those that have the highest quality ratings get a portion of those dollars back. In fact, more than they would have gotten had they been paid the regular way. And so it's an incentive for hospitals to do well on quality and to improve their quality and thereby get paid more. And a disincentive for hospitals that are not high quality providers, they're going to get paid less. And it's a way of addressing that very issue about just paying for volume versus paying for quality of care. That's really, it's a modest program in the Affordable Care Act, but that's a huge change in the way that this federal government, our federal government, reimburses healthcare providers. And I think you're starting to see the same trend with private payers and providers as well. You'll clearly see that across the board. There are these things you've probably heard of, ACOs, Accountable Care Organizations, which are intended to be much more integrated systems of care rather than the fairly fragmented system of care that we have today. And you can see kind of models of this, the Geisinger Health System, the Intermountain Health System, Kaiser Permanente. Those are the kinds of systems of care that these ACOs kind of are modeled after. And what they do is they allow providers to share in the savings that they achieve. So if a set of patients in the next year can be treated by an accountable care organization, which is a hospital system coupled with physicians, primary care physicians, and a whole confluence of providers that organize themselves better, and they decrease inefficiencies and they increase outcomes of patients, and they eliminate a lot of duplication and waste, they can save money for the Medicare program. And if they save money for a particular set of patients greater than what they expected to spend based on what they're proposed or projected to spend, the providers themselves, the Accountable Care Organization, can share in the amount that they save to the federal government. The federal government sends them money, and they distribute those dollars to providers within the network. It's a way of incentivizing people to be more efficient than they currently are. That's what's behind the Accountable Care Organizations. I'm sorry, Accountable Care Organizations, ACOs. And the rub is that no one's certain that this will work. A lot of effort has gone into this. A lot of people around the country are organizing ACOs and trying to figure out how to do this. And yet there's very little evidence that there can be a huge achievement of savings under these programs. And so we're going to have to see where that goes in the future. There's also a very similar concept called bundling. And this is another Medicare concept where Medicare is taking episodes of care and bundling them together and paying the provider one rate to pay for that individual's bundle of care. So let me give you an example. Right now, a person shows up at the hospital with a heart problem, and the hospital receives what's called a DRG payment, an episode-based payment. Let's say that person needs some rehabilitation, so they get discharged to an inpatient rehabilitation hospital. That the inpatient rehabilitation hospital gets a separate payment from Medicare. Then they're discharged for some home health care and some outpatient therapy. Both of those two settings of care get separate payments from Medicare. When you add up all the costs of that across that entire episode of care, let's say it takes 4 months, and that episode is 4 months, the theory is that you could do it much better if you bundled that episode of care together. You paid the hospital or some entity, you paid one rate, one bundled payment, and make sure that that entity organizes the care across that continuum and covers the episode of care so that that beneficiary comes out as well, if not better, at the end. That's the theory behind bundling, and that's something that Medicare is working on very hard right now to try to do. And finally, one of the responses to bundling by the inpatient rehabilitation hospital field was to propose what they call the continuing care hospital concept. And that really is merging 3 settings of care that exist today: the inpatient rehab hospital or unit, the long-term acute care hospital, and hospital-based skilled nursing facilities, merging those 3 things together and having a patient be discharged from an acute care hospital to that setting, the CCH setting, and having those post-acute care decisions made by the rehab team and the physician in charge, and giving the bundle to the post-acute care entity, that CCH hospital. It's a kind of a response to the fear that rehab hospitals in particular have that they're going to be at the end of the food chain, and that if you give the bundled payment to the acute care hospital, the post-acute care is going to suffer. And so that's an approach that has been suggested to counter that. So there's 3 more settings that I'm going to delve into in much greater detail: the Independence at Home demonstration project, home and community care, home and community-based programs that are under the Affordable Care Act, and the medical home demonstrations. The Independence at Home program is modeled after the ACO concept, but it's designed specifically for people with chronic conditions. So in order to even be in I'll call it an IAH program, the Independence at Home program. This is a Medicare program. It's a demonstration project, so it's set to run between June 1 of 2012 this year and May 31 of 2015. It only applies, you can only have up to a total of 10,000 Medicare beneficiaries in the in each IAH program. A number of these programs have been selected by Department of Health and Human Services already. It adds a new benefit for chronic care coordination. So it actually pays providers to coordinate the care of a chronically ill or disabled population. That's a new benefit under the Medicare program. And the theory is that they'll pay that money, but the coordination itself is going to save the program a lot down the road. When you have people with 2 or 3 chronic conditions, you've got a lot of medications, you've got a lot of services being provided, and there's a lot of duplication, there's a lot of inefficiency, and the theory is that if you just coordinate that care better, you're going to be able to decrease a fair amount of costs. Much like the ACOs, the IAH programs can share in savings. In fact, if they achieve anything more than a 5% decrease in costs, they share 80%, the providers share 80% of the amount saved over that 5% savings, and only 20% is saved by the federal government. That's a big incentive for IAH programs, especially with chronic care populations that are quite costly. You know the old statistic, 80% of the Medicare dollars are spent on 20% of the beneficiaries. It's that 20% that this program is really targeting. Okay. The next set of programs are home and community-based programs under the Affordable Care Act. Oh my, I forgot to advance the slides. My apologies. You should have them all in front of you, right? Great, sorry about that. I'm all the way up to here now. Money Follows the Person is one program, New Balancing Incentives is another program, and Community-Based Care Transition Program, that's a third program under the Affordable Care Act, all designed to do basically one thing: put the dollars and put the decision-making into the hands of the Medicaid beneficiaries and allow them much greater choice in where they get services. So this is an attempt, a multi-pronged attempt, to get more people out of institution-based care under Medicaid and into care provided in their homes and in the community. And so it's a real important effort led by people with disabilities and organizations representing people with disabilities. The Money Follows the Person program, the dollars actually are spent by the individual. They're not spent by a provider or anything like that. They are held by the individual in a bank account, and cash is spent to assist with personal assistance services or other kind of home and community-based services to allow that person to live independently as possible. The Affordable Care Act extended this program. It was already in effect, but it extended it to 2016 and added $2.25 billion of additional funding. And thus far, this program has helped 19,000 people transition from institutions into their homes and communities to live independently. So a lot of people with disabilities, including people with intellectual and developmental disabilities, oftentimes wind up in institutions because the state doesn't quite know what else to do or doesn't have the capacity in the home and community-based setting to provide services, and yet that's where the person wants to stay, and in many instances that's a much cheaper way to go for the state. The next process or program is has the exact same goal, and that is to increase the state matching rate, federal matching rate, if the state removes people from the institution and places them in the home and community-based setting for additional care. They actually get a 6% increase in the amount of funding that the federal government sends to the states, and so that's a financial incentive to do that. And one of the states is Missouri. There's 8 states that are participating in this new balancing incentives program, and Missouri is one. Did I get it right, Missouri? A little local flavor. And then the third proposal or program is the Community-Based Care Transitions Program. This is strictly a grant program. It's got about $500 million of funding devoted to it, and it is designed to try to get people out of the hospital and into the home and community-based setting, and to make sure that their care needs are met during that transition so that they're not readmitted. In terms of medical homes are really, there's a couple of different types of medical homes. Some people call them health homes. There's different programs under the Affordable Care Act, under both Medicaid and under the broader healthcare system that address this basic concept. The basic concept, I think, is one, and you probably have already known this from your prior presentations, and you'll probably be talking about it for the rest of the day. But the basic concept is to center care in a very person-centered way with very significant access to home-based care and have an individual know exactly who they call for all of their healthcare needs. And that becomes their health home or their medical home. And that concept is designed to do the exact same things that these other concepts are designed to do. And that is integrate care, reduce inefficiency, increase and better outcomes, eliminate waste to the maximum extent possible. Just a different model for doing it. There's a couple of different programs, as I said. There's a multi-payer, multi-payer advanced primary care demonstration, and that's where states conducting multi-payer reform initiatives include CMS, and in other words, CMS is a partner in that initiative. The advanced primary care practice model or medical home utilizes a team approach to care for the patient, with the patient being at the center of all care decisions. 8 states were identified to host these demonstration sites, and in order to participate, practices have to meet certain requirements. I dropped off specifically what those requirements were. I neglected to get rid of the 2. But the requirements are pretty detailed, and they're based on state requirements. There's also a CPC initiative. It's called the Comprehensive Primary Care Initiative. It's a 4-year demonstration project. It involves 500 primary care practices across the country to participate in this program. The practices receive a $20 per month management fee for each patient, for each Medicare beneficiary, and that fee is designed to better coordinate their care, to hire a nurse or someone within their structure to follow up, to make sure that the patients go to their appointments, to make sure they know what their treatment regimen is, that they're showing up, that they're taking their meds on time, that they're not crossing meds and inappropriately caring for themselves. Medicaid plans are also offering enhanced payment for better care management. And right now, CMS estimates that over 300,000 Medicare beneficiaries will be served by over 2,000 providers through this program. Medical homes, they're under Medicaid, they call them health homes under this new program. It's an optional benefit under Medicaid. States can choose to adopt this model if they like. The Affordable Care Act provides 90% federal match, even for existing people covered by the program, so not this new set of expanded eligibles, but the existing Medicaid population. Right now, many states get a 50% matching rate from the federal government, so this expands the amount of federal funding for this program dramatically. 90% federal matching rate for the first 8 quarters of care of people in this program. And that's a huge incentive for the states to develop the necessary program infrastructure to treat people with a medical or health home model. CMS is supposed to evaluate the effect of home health services and on the cost and quality of the care provided. Home health services include a whole host of types of services that some might not view traditionally as being covered by Medicaid, but they in fact are. They include a whole host of comprehensive care management, care coordination, transitional services, as well as primary, acute, behavioral, and long-term management, as well as long-term services and support. So this is a very comprehensive set of benefits under this program, and it's really designed to keep people healthy, as functional as possible, living independently as possible, with the best outcomes possible at the lowest cost. Every person in the Medicaid health homes has to be a person with at least 2 chronic conditions or have a chronic condition and at high risk of developing another chronic condition or have a serious and persistent mental health disorder. So this is targeting the same basic concepts that the ACOs are targeting with respect to a primary care model, but it's targeting them on these models on chronically ill populations. Again, the 20% where we spend most of the Medicare dollars. Additional slides on Medicaid medical homes. Depending on the state, a home health provider can be a designated provider, such as a physician or community health center, or pediatrician, home health agency, or rural health clinic, a team of healthcare providers, or a team of professionals working with a designated provider. So there's a couple of different models that providers can arrange themselves to participate in this program. The states will be required to regularly report outcomes and evaluate the effectiveness. And I must tell you that, as I said, legitimate questions do exist about whether these entities will work in the first place, but also whether the measurement tools are granular enough to really assess whether an individual is getting better outcomes in these programs or not. And that's going to be a real big issue, whether a person in the ACO where you've got shared savings and financial incentives to coordinate and organize care, is that really just going to be a way of skimping on services and denying patients what they otherwise are required to receive or permitted or entitled to receive? And that's a big question. Are the measurement tools fine enough to really assess whether the patient's getting value for what they're in that new program? And again, 6 states, including Missouri, have approved health home state plan amendments, and those are options that the state can choose to participate in if they like. There are also federally qualified health centers that have a new medical home concept that's been placed on them. These 3 federal agencies here, CMS, CMMI, and HRSA, I won't go into all the long acronyms, but they established a 3-year federally qualified health center advanced primary care practice demonstration project. And this essentially functions out of the federally qualified health centers and is directed to be essentially a health home for those people that typically go to those centers. The goal is to provide integrated, coordinated care through a patient-centered delivery approach to patients. Again, very similar to these other mechanisms, delivery models that we've talked about. There are over 500 federally qualified health center primary care practice demonstrations sites across the country, and it's expected to impact 195,000 Medicare beneficiaries. And finally, in order to help the participating centers transition, CMS does pay a monthly management fee for each eligible Medicare patient. All right, I'm rounding the last 2 slides here just to give you a heads up. Am I exceeding? Did I exceed my time? Okay. So all of this, as I kind of just briefly mentioned, really important that you measure quality, that you measure whether the beneficiary is just getting stinted on care or whether they're actually improving their outcomes. And you have to have measurement tools, especially in the chronic illness and disability population, that measure that sufficiently, with sufficient granularity or detail to make sure that you're really assessing what's happening with that patient. The Agency for Healthcare Research and Quality, it's a federal agency, and the National Quality Forum, which is a public-private partnership, they're responsible for identifying quality indicators for a variety of things, but in particular, transition to post-acute care and pay for performance. They have a measures application panel that is a committee that works on post-acute care and long-term care measurement tools and trying to assess tools that will be widely adopted in the field and in the community and accepted. There's a work group that will provide recommendations on these measures for post-acute care providers, and that work is ongoing. There's also a significant focus on utilizing measures for patient experience and satisfaction. And there's at least one tool out there called USpeak, which is an instrument, and it's a model that measures the experience of the patient served in whatever program they go through. This is a proprietary product of CARF, the Commission on Accreditation of Rehabilitation Facilities, and full disclosure, I represent them. But this is a tool, it's probably the only one of its kind, I think, that really does measure the end user's experience, and it's got widespread adoption, and the federal government is looking at it very seriously for assessment of the patient's experience with many of these different programs. So, what's the kind of the concluding thoughts that I want to leave you with? Well, first off, there is a continued emphasis of the federal government on bending the cost curve in healthcare and bending that cost curve downward. I just read yesterday that census data suggests that the middle class is getting squeezed and having a tougher time paying its bills. The wealthier are getting wealthier. There's an increase in the insured rate of, again, 1.3%, which is pretty good news. And there's a moderation of healthcare premiums. Healthcare has gone up in cost at a much lower rate over the last 3 years than many people expected. And that's not all, by any means, the result of the Affordable Care Act, because many of the Affordable Care Act provisions have not even yet gone into effect. But I would say that the trend lines are moving in the right direction. But we're still spending 18% of our gross national product on healthcare. And that's a huge amount, and it's double, more than double, of any other developed nation. And we spend more than double on healthcare than any other developed nation in this, across the world. So the emphasis on bending the cost curve and care coordination and improving quality will continue, regardless of what happens in the election, regardless of whether the Affordable Care Act is repealed or not. The healthcare industry and the healthcare field is moving along all of these lines that I've already told you about. And whether or not the Affordable Care Act survives, that is where the market is going. Developing medical home models remains an opportunity, I think, for providers and for systems of care to innovate, to improve care, and to do so through alternative delivery mechanisms and new delivery mechanisms, some of which allow the sharing of savings as a financial incentive to do these programs. And finally, patient-centered care and care coordination will remain important trends, again, whether or not the ACA is repealed. So with that, I hope that builds a little bit of perspective and context around the importance of medical homes and the importance of health homes, the importance of integration of care, the importance of community and home-based care, and all of the things, hopefully, that you'll be talking about. This talk will be at least somewhat relevant to your ongoing discussions. So with that, I'll thank you very much and take your questions. Any questions? Yes. Yeah, it's in the slides. It's called USpeak, USPEQ, And it's it's a product. If you go onto the CARF website, if you Google CARF, carf.org, that's an accrediting organization for rehabilitation providers and programs, and you'd be able to find out more information on U-Speak as a result of that search.
Then I have another question. The pay for performance program, I know this is probably something that has been going on in the community. What are the outcomes of the pay for performance? Did we see a better outcome with what we actually started doing pay for performance in the community versus doing it right now? Because it's still going in home care agencies where they actually doing pay for performance. Am I correct?
Yeah, no, it's a great question. And I think with a lot of the programs that I laid out today, the jury's not in yet. The data is just not in. I mean, there have been demonstration projects on paper for performance conducted by CMS, the Centers for Medicare and Medicaid Services, on the physician side of things under Medicare. And some of those have demonstrated some valuable outcomes. There is literature that suggests that pay for performance can improve quality and decrease unnecessary waste and inefficiency. But I think the broad, those concepts were inserted into this legislation in a variety of different ways, and many of them I've talked about today. And I do think, though, that a real critical analysis of that would have to expose that the jury is just not in as to whether these programs can work and whether they can save money. And that's what the government is most interested in, saving money, bending the cost curve, and hopefully improving quality. But the main goal is to save money and to do it in a way that you're not skimping on care and stinting on care provided to beneficiaries. So I think the jury's still out on that.
So don't you think it'd be really good that if they do, with us doing the quality care, that it gives a better opportunity to give all the funding to the organizations in the community that are doing a great job versus, and then weeding out the ones who are just flying by the seat of their pants and not giving quality of care? Wouldn't that be a good?
Well, any organization that can demonstrate that they are getting better outcomes, that they are doing better than other providers, is going to be much more apt to be adopted into some of these systems and receive those funds than providers that can't demonstrate that. That's why those measurement tools are so important. You say that we're doing a better job than some of the bad apples. You need to show it. You need to demonstrate it. And if you can create metrics that demonstrate that, that is what's going to allow you to be adopted by and incorporated into ACOs, into all kinds of mechanisms, into pay for performance systems, because you have to demonstrate your value. That's the way of the future. Any other questions? All right, my time is up. Thank you very much. Have a great conference.